Scott Pace with us on the podcast today. Scott, we've been colleagues for, I guess, a couple decades now, but maybe you could just give us just a quick background of your history in pharmacy and your role.
Well, again, thanks, Ron, for having me on. Yeah, we've known each other for quite a long time now. With Missouri and Arkansas being situated right next to each other, we've had a good relationship over the years, and I've always appreciated that. Well, as Ron said, my name is Scott Pace, and I'm a pharmacist lawyer from the state of Arkansas who has worked in the advocacy world for pharmacy for 20 plus years, starting with a stint at NCPA and then spending a dozen years with the Arkansas Pharmacist Association as their chief operating officer and then ultimately their chief executive officer, where we fought a lot of PBM battles through the years in Arkansas and had some successes that are still reverberating today around the nation, and seeing other people take those and run with them too, which is great. I also own part of 3 different independent pharmacies in the state of Arkansas, and so not just working on the policy side of the profession, but working on the day-to-day operations side, trying to make sure that these pharmacies can stay profitable in the environment that we're all living in, so that we can serve patients in our states. So today, for a full-time job outside of running the pharmacy, I'm also a partner with a group called Impact Management Group, where I do government relations work across the healthcare spectrum. So that's me in a nutshell, Ron. But still a huge pharmacist advocate and work on these issues every day for a variety of different clients. So happy to be with you today.
Well, it's great. It's great to be with you as well. When I joined pharmacy back in the early 2000s, my first meeting was to go to a National Community Pharmacists Association meeting, and there was this guy by the name of John Rector there. He was talking about PBMs. I didn't even know what a PBM was, and here we are 2 decades later still talking about PBMs. As you've watched this issue grow, how has it changed from those early days? Because I know that their impact was not as significant, but today, well, they're in every aspect of pharmacy.
Yeah, that's a great question. Yeah, I know if you go back, I was probably at that early meeting that you were at with Rector. I can't remember the exact one, but if you go back to those early days in the late 90s, early 2000s, they were claims processors, right? They were getting into the formulary development and rebate game, but for the most part, they were processing claims. They were the Visas and MasterCards of the healthcare world, processing electronic claims, verifying eligibility, setting up a network, etc. Flash forward 20 years, and they own insurance companies. They own mail order pharmacies. They own retail pharmacy chains. They own specialty pharmacies. They own doctors' clinics. They own, in some cases, personal care companies. They go into patients' homes directly. They've gone from being the processor to the healthcare system, and really their next step is acquiring physician practices, and the way that I see it. I mean, that's the only piece of what I don't see in their arsenal today is the ownership of hospitals and physicians practices, and some of them are starting to dip into that area. So it's really it's socialized medicine as much as it can get, except it's owned by the people that you would least trust, even more than your government, the big PBMs.
Well, I know having one of the big 3 here in the state of Missouri has been a challenge for us. What we found is about the only way that we can try to address our issues is that the state legislature, and it's a very complicated process. I know Arkansas has had some success, some other states around the country. As you look at the current PBM and the current industry and talk to other states, what are the 3 most egregious things that they're doing to impact pharmacists and ultimately pharmacist patients?
Golly, just 3, huh? Well, I think the first thing that comes to mind, Ron, is they're denying both patients and prescribers the freedom of choice of how medicine is practiced and how pharmacy services are delivered, right? I mean, they are taking away patient choice on which pharmacy they can use. They are taking away medical practice choice of prescribers by letting them describe which drug is really best for which patient. And that lack of relational piece of medicine and pharmacy is a loss for the consumer, is a loss for the healthcare system, and they've stripped that away. So that's number one. Number two, I think they have taken away the ability for costs to be controlled in healthcare by creating a system where they are perversely incentivized for costs going up. People listen to their line that they save X number of dollars in healthcare, but the truth of the matter is that when a pharmacy dispenses a $500 prescription, when there's one that's a $20 prescription that will work just as well, simply because the PBM dictates that the $500 one is the only one that will be paid for, that's messed up. And they're doing it because they're profiting in the center. So I would say that's number two, is the perverse incentives to drive up the cost of healthcare is one of the bad things that they've done. And then number three, excuse me, when you look at the workforce issues that you're seeing in your state in Kansas City and others are seeing around the country, that is a direct result of 20 plus years of racing to the bottom on reimbursement with pharmacy reimbursement that the PBMs have set over these decades. They have squeezed margin out of the pharmacy world, so much so that pharmacists are losing money left and right on prescriptions. And as a result, the big chains and even some independents are having to adjust their staffing just to keep their heads above water financially. But in doing so, they're jeopardizing the mental health, the safety of their pharmacists and their pharmacy staff. They're jeopardizing wait times for pharmacy customers. And really, they're just breaking the system. So what I would say is that you've taken away patient choice and doctor choice. That's bad. You're driving up the cost of healthcare. That's bad. They're diminishing working conditions in the healthcare space. That's bad. Which begs the question: what value do these people bring to the system to begin with?
It's interesting to see that. Yet you've talked to a lot of legislators. I talk to legislators, if not every day, it's certainly every week. And it's hard to get that message across to legislators. I mean, their pat answer is just do a better job of contracting. Just work a better deal with these individuals. And as you all know, you cannot contract with a PBM. You get a take it or leave it contract. So how does a pharmacist get around that argument and get the real message to a legislator?
Well, I mean, part of my background is being a lawyer, and so I talk in a lot of analogies because I think that's helpful for people to understand what you're dealing with. Because when we get into the situation of trying to explain every nuance of the pharmacy world or every nuance of the PBM world, people's eyes glaze over in about 30 seconds, and it probably takes 15 minutes to tell the baseline story. So you've dealt with that. That's hard to do. So I try to talk in analogies, and you and I were talking the other day, and one of the best analogies that I can come up with that I stole from one of my mentors, Mark Riley, is the analogy of trying to contract with your electric company. You can try to choose to call your energy provider and say, "Hey, I don't like this rate per kilowatt hour that you're selling me electricity." But their answer is going to be, that's what it costs. You either want your electricity or you don't want electricity. And that's what pharmacies are dealing with when it comes to these take it or leave it contracts. They get these rates shoved in their face and they're told, here's your rate. And the pharmacy will say, well, we don't like that rate. We need it to be higher. We can't stay open at that rate. And their answer back from the PBM is, do you want your patients to come into your pharmacy or not? You can have patients or not have patients. And really, it's that gun to the head model that has proliferated through this industry. And frankly, it's not just pharmacy. I do think that the hospitals and doctors are in similar boats, but arguably because of clinically integrated networks and the size of some health systems, they do have some additional, contracting leverage that pharmacy just doesn't at the independent level in particular. And even the chains are having a hard time negotiating, especially when one of the biggest chains in the country is owned by one of the big PBMs. So, take it or leave it is real. And if people have ever tried to negotiate with their electric company or their gas company, or tried to, negotiate for anything with a monopoly, which is essentially what we're dealing with here, it doesn't go very well.
But you also mentioned, and I mean, I think we both know we've got a train wreck coming at the end of this year. I mean, as we talked about PBMs in the early 2000s, they were doing the activities that you indicated. We poked at them a little bit. But then Medicare Part D came in, and it seems like they have ramped up their activities incredibly since Medicare Part D put in this function called direct and indirect remuneration, DIR fees. And can you talk to our pharmacists a little bit about the train wreck that's coming at the end of the year and the impact that it's going to have, especially on some of our community pharmacies?
Yeah, well, I mean, I think DIR fees, we have to recognize that phrase has existed in federal law since the advent of the Medicare Modernization Act, which was passed in 2003, but didn't go into effect until 2006 with that full Medicare Part D benefit. And DIR, direct indirect remuneration, was really not anything that was used. It was an undefined term in federal law. And you got to give the PBMs credit for being clever. Some attorney, I'm sure, in one of the big PBMs decided, hey, look, there's this caveat that we can extract some extra price concession from pharmacies via this term. Let's define it. It doesn't have a definition. And they started using that initially to essentially create a pay-to-play way to have a preferred versus non-preferred network in the Medicare Part D space. And they were nominal fees in exchange for being a preferred provider for the next benefit year. And what we've seen over the last 5 or 6 years, maybe 7 or 8 at this point, is that DIR fees have literally just become a gun to your head extraction that the PBMs are going to take from you months after you've filled the claim. So there's never any real opportunity for you to know at the point of adjudication what your true reimbursement is. And so that's caused a lot of challenges for pharmacies over the last several years. It's caused a number of them to go out of business as these fees have gotten bigger and bigger. And it actually finally, caused the federal government to step in and go, okay, we've got to do something. And so starting in 2024, the lowest best price will actually be what you see at the point of adjudication. So there won't be any retroactive return of these DIR fees. So essentially the DIR concept is going away. So that's good from at least knowing what your price is going to be at the point of adjudication. It's not necessarily going to make that price any bigger. It's just going to give you insight into what that number is, which, you can take that as good or bad. You can either see how bad you're getting screwed on the front end, or you can see if there's anything you can do about it at the time of filling the prescription. And that's the attitude I hope most people will take is don't just throw your hands up and go, can't do anything. I hope people will go, I'm not going to take a $15 loss on this prescription. Let's see if we can switch them to another drug, or let's see if there's something else we can do here, or if we're going to say if you need to turn the patient away because it will harm your patients long term if you go in the red, that's a decision to make too. And I do think people are going to have to be really pragmatic about that. That all is going to be complicated with the fact that there's still going to be these fees that people have incurred in 2023 that will be collected through the first 4 months of 2024. So you're going to see those net reimbursements at the point of adjudication at the same time that you're still going to owe for some of those back fees from 2023. I think it's going to create a real cash flow crisis for many pharmacies going into 2024. And I'll just say this, Ron, this is non-PBM related, but it is directly cash flow related. All this is happening at the time when a new COVID booster is coming to the market. And for the first time, pharmacies are expected to actually buy the booster and bill the insurance for both the booster and the administration fee. And that's going to create cash flow issues too, because these doses, which we used to be provided to us by the federal government, all of a sudden have a big cost and a big cash flow hit to us at a time when cash flow is already going to be impacted by this DIR issue. So just recognize that there's a tsunami of perfect storm coming up as we enter the first of 2024 that I hope people are prepared for. And I hope that they're ready to react to and not just throw their hands up to.
How do pharmacists get themselves ready to assist us in the legislature? What do you think of the issues that they ought to push back on? I mean, our session starts again in January. We're going back in aggressive. How do we get, I mean, our pharmacists understand a bit. How do we get them to take that understanding and put it into action?
Well, I think the first thing is to have a clear, cogent message of what you want and why, and have the data to support it. And that's part of what the associations have to drum up and lead the charge on. I don't know what is your number one issue in Missouri, but I can tell you from my perspective, if I was trying to drive the boat in a state today, I would try to be establishing a mandatory minimum ingredient cost and a mandatory minimum professional service fee going forward. I just think that unless that is codified, um, any other PBM tightening of licensure or restrictions on activity aren't going to be as successful unless you can shore up a baseline reimbursement model for the profession. And that to me is what everybody is screaming about right now. They may not be saying it in as succinct of a way, but if you can't guarantee me that I get my cost of my drug back and the cost to operate back, then it's going to be a pretty challenging world over the next several months and years. So I think they got to get behind the message. They got to coalesce. They got to know their local House and Senate members, and they have to be real with them about how dire things are. But they also have to be cognizant that it's bigger than just them, and that's the piece that I think that pharmacists sometimes fixate on. Here's what it means to me. Yeah, I get it. Everybody has an issue that means something to them. What does it mean to your community? What does it mean to your patients? What does it mean to your little league team that you've been sponsoring for 25 years if you're not there tomorrow? What does it mean for your local hospital if somebody's not there to get a Finnegan suppository for somebody who's discharged from the emergency room at 2:30 in the morning who happens to be your principal at your local elementary school? Those are the things that when a community lose, they don't get that back from mail order pharmacy. They don't get that back from a corporate pharmacy. That happens when a local pharmacy is there and everybody benefits from that. And you got to tell that story.
Well, and you mentioned just a little while ago the event that happened in Kansas City, and I think most state associations have always been dominated by independent pharmacists. I mean, independent pharmacy started the profession, but as it became more of a corporate medicine, some of the partners drifted away, and I think the pharmacists in the chains are now starting to see that maybe the messages that we were putting out there are real. The reimbursement, as you indicated, is now affecting them. And they've done a good job of shifting the concerns to the patient. I mean, they talked about patient safety issues, understaffing. And as I talked to some of them, I didn't get the message that they were talking about themselves. They're concerned about their technicians, reimbursement for technicians, having qualified technicians, and it all relates to the activities of PBMs. So we've had the opportunity for the media to finally catch that message, and I think as you indicated, we've got to continue to push the impact that it's having on patients, and then ultimately the impact that it's having on pharmacists. And I know you've been very successful with that message in Arkansas.
Yeah, we have, and I'm glad you brought up the point about the Kansas City folks. Look, let me just start by saying kudos to my brethren that work in the chain pharmacy environment. I was a chain pharmacist early in my career, and relished the opportunity to work in that environment and learn from that environment. I also personally prefer an environment where I have more day-to-day autonomy. But look, it's hard in the trenches at the bench if you're working for a chain, to understand what the potential long-term benefits of a PBM, um, you know, harming independent pharmacy was 20 years ago or 10 years ago. So I get it that they didn't necessarily think that that was their issue. They thought that was the owner's issue. But I think, as you mentioned, what we're seeing today is that the 20-year erosion of the pricing model, the continued breaking of the broken reimbursement system by the pharmacy benefit manager community, it's affecting everybody. And those corporate executives are hell bent on protecting their quarterly profits. They're publicly traded. They have to have good earnings calls. They have to have good profit numbers, and they're going to preserve that at whatever manner they can. And that has severely impacted patient quality. That has severely impacted pharmacists' work life in these chain environments. It's impacted staffing. And frankly, I think it's created a public health safety issue. And I just really applaud those pharmacists for drawing a line in the sand and saying enough is enough. And it's a real issue, and it is a direct downstream effect of the PBM issues. And I will say, to your point, you're right. I haven't seen a single pharmacist in that Kansas City walkout talking about, I want more money for me. Are they underpaid? You bet, for what they're being expected to do. But they're out there talking about, I need help. I need more technicians. I need a safer working environment. I need a bathroom break. The humanity of asking to go pee in the middle of a workday. Can you imagine that being vilified by your employer? I mean, this is absolutely crazy that we've got Fortune 20 companies that are treating people with doctorate level degrees like they're, not valued. And that's really, I think, where we are in the profession right now, where we've got MBAs and bean counters who don't know, anything about a prescription medication and the potential dangerous impacts on what it can and can't do in a human body, dictating to highly trained clinicians that they just need more and more, faster, faster. And it's hit a breaking point. And I applaud our colleagues for keeping that message focused on the patient and for drawing a line and saying enough's enough.
Well, and I agree. And one of the pushbacks when we were talking to them was that, at least one of them, that some of the top individuals are pharmacists. And their response was, they've drank the Kool-Aid. They don't remember what it was like doing their jobs, and they're frustrated that even pharmacists in some of these corporations. So we've got to continue to keep that message out there of what's happening. And I think there's a role for the board of pharmacy and for others to help continue that message that it is about the patients, and these PBMs are having a direct impact. And I agree with you. I applaud them. We had great discussions with some of them. And obviously, as an association, we can't lead the charge, but we can respond to activities that are going on around us. And legislators are taking notice, and the media is taking notice.
Yeah, and look, we need to be cognizant, and I understand there are pharmacists that do work higher up in those corporate environments. I think we need to be real with ourselves that the last time that some of those folks were behind the counter, pharmacy probably looked really different too. I mean, if we're looking at, I'll take you back my first year of pharmacy school, which has been 25 plus years ago now. We were the first P1 class in Arkansas that were trained. I think we were trained as P3s, but as we came in, we were the first class that had the statutory ability to immunize as the first full class. That happened in 1997 in our state. And so when we got trained to give vaccines, that was just part of the normal curriculum. But if you came into school before 1997, that was something you had to go back to learn and decide if you wanted to vaccinate. And flash forward 26 years later, pharmacists gave 80+% of the COVID vaccine in the state of Arkansas. If we hadn't had that law changed in 1997, um, what would the pandemic have looked like? My point in saying that isn't to pat ourselves on the back. It's to say that pharmacy in 1997 does not look the same as pharmacy in 2023 in terms of what your day-to-day work requirements are. And somewhere in there, medication therapy management got plunked in, and comprehensive medication reviews, and point of care testing, and oral contraceptive prescribing, and strep and flu testing and treating. And so when you go through And all that's great, by the way. That's that scope of practice expansion that we've all been, yearning for and wanting to do. But I don't think our workflows have necessarily evolved as well as they need to be able to on the fly implement those things. That's one of the things I love about owning an independent pharmacy. If there's something that's not working today, I can change it tonight and implement that tomorrow. I know that's a harder thing to do in a chain. And so I just think we need to realize those corporate people may, to some extent, be working with an antiquated model of pharmacy in their head, and it doesn't fit in where today's practice model is. And I also think, let's just be clear about this too, metrics don't belong in healthcare. I mean, if you are telling someone that if they don't fill X number of prescriptions an hour or give X number of vaccines an hour or do X number of MTMs a week, that they're a failure, that is the wrong way to hold people accountable, because all you're doing is continuing to devalue the professionalism that exists in our profession. That should be something that I think we should generally fight against. We should be empowering the clinician to make the right clinical decisions, not empowering the bean counter to put numbers over people's heads and point a gun to their head. That's wrong.
Well, it's fascinating, and a couple of the pharmacists did indicate, the metrics were really impacting their ability to be professionals. And they said, we're trying to spend time with patients, and we have to hit targets and metrics. And if I need to spend 30 minutes with a patient, then I need to do it, and we're not allowed to do it. I mean, we can't hit our numbers. So I think that's a very valid point. It's still a fascinating
You
discussion. What have we left out? What have I missed on the discussion?
I mean, there's a lot to talk about. Before we get off the workforce issue, I want to see if I can find a post on a pharmacist message board that I saw just about a week ago. It was a chain pharmacist friend who got on there and posted about what their expectancies are every day, and he broke it down by hour by hour by hour in terms of how many prescriptions they're expected to fill, how many prescriptions they're expected to check, how many patients they're expected to counsel, how many immunizations they're expected to give, etc. And they assigned in this post a reasonable time for doing each of those tasks. And to meet their metrics in a 60-minute hour, they needed about 95 minutes in every hour to meet the metrics that they were expected to do. And so I guess my point is that that's why metrics don't work. You can't, number one, make up time in a day, as we all know. And number two, people are just missing out the emotional and physical weight that puts on folks' shoulders in terms of wanting to be at work, in terms of being focused at work, and in terms of being able to really do the job well that they're doing. We just got to stand up to our corporate folks who should be partners in the profession, not slave drivers, and say we got to find a better way. And I think that's part of the association's jobs, is to help facilitate those dialogues, and I hope we do. So that's a big issue coming down the road. The wellness initiatives that we've heard about, those can sound touchy feely. At the end of the day, their patient safety, their pharmacist safety, their community safety issues, and that's how we should really focus on those.
Well, I appreciate your time. I know we've had a lot of discussions on the PBM issue and the impact that it had. I've always appreciated the work that you've done. We're going to continue to talk. As I indicated, we've got an aggressive session we're anticipating in 2024. So I'll probably be calling on you again. But any last parting words? Anything our pharmacists need to know?
Yeah, I would just say, look, guys, remember that it is never a flip the light switch moment in the world of politics. Whenever we passed our PBM licensure bill in Arkansas in 2018, it was a big moment. It came as a result of a crisis, and it also came 15 years after the first PBM licensure bill was introduced in the legislature in Arkansas and didn't succeed. And after the governor signed that law, which has really, I think, made some meaningful impact in our state, but after he signed that law in 2018, He gave us a handful of the pens that he used to sign it with. And I gave two of the pens specifically, one to Mark Riley, who was my predecessor as CEO, who helped to file that original bill back in 2003, and former State Senator Percy Malone, who was the author of that first licensure bill in 2003 that didn't get passed into law. And I did that specifically to show the pharmacists that were in the room that we are never in a on-off um, kind of process in the political world. It is always a journey and rarely a destination. So remind your members that everything they do today, even if it doesn't bear fruit tomorrow, will eventually bear fruit down the line. And that's hard for us to get our head around because we like instant gratification. But tilling the soil, putting down the fertilizer, getting the right seeds, watering it, nurturing it, growing it is the way that you ultimately have success in politics. So keep on doing what you're doing. Missouri is fortunate to have MPA. Ron, you're like the dean of the state pharmacy associations in terms of tenure and success, and I appreciate what you do, and your members are lucky to have you working for them in Jeff City.